Sean. I'm a screening midwife in Chelsea and Westminster Hospital, and on behalf of the West London Haemoglobinopathy Coordinating Centre, I'd like to welcome you all today to our Sickle Cell and Thalassemia Midwifery education session, and just to thank you all for coming along. I am just going to take you through our session this morning and introduce you to my colleagues who are going to be presenting their topics today. So firstly, we're going to have Carmen, who's the Antenatal and Newborn Screening Coordinator in Queen Charlotte's Hospital. And she is going to be presenting on the slides that are up on the screen at the moment. So she's going to be talking about practical application of genetics in midwifery, and that's in relation to sickle cell and thalassemia. Then after Carmen, we're going to have Joyce, who's a specialist haemoglobinopathies midwife in St. George's Hospital. And she's going to be presenting on sickle cell disease in pregnancy, specifically preconception and antenatal care. And then after Joyce, we're going to have Paula, who is also a specialist haemoglobinopathies midwife, and Helen Hosking, who's a same specialist haemoglobinopathies midwife in Hillingdon, and they are both going to be presenting. So it's going to be on sickle cell disease in pregnancy, and that's going to be split into labour care and then postnatal care. And finally, we're going to have a guest speaker today. So it's a patient who is going to talk about her experience of sickle cell disease in pregnancy. We're going to try to allow for a few questions between each session. So if you could put those in the chat, I think that would probably be really helpful so we can keep track of them. And then at the end, we're going to have some time for more questions afterwards. So I think if that's okay, if Carmen is ready to start with her presentation.
Oh, thank you, Shona.
Thank you.
So, good morning all. Thank you for coming today. My name is Carmen. I'm, like Shona has just mentioned, I'm one of the antenatal and newborn screening coordinators at Imperial, based at Queen Charlotte's as my main site. So the presentation today is about sickle cell and thalassemia and practical applications of genomics in midwifery. Next slide, Ralph, please. So you may all be familiar with the concept of genetics, but the concept of genomics is less well understood at the moment. So genetics is the study of genes and their role in inheritance. So it refers to the way that certain traits or conditions are passed down in the genes from one generation to the next in the same families. In healthcare, genetics has typically focused on variations in a single gene, and we're looking at the cause of a health condition. On the other hand, genomics describes how we interpret and act on information from the whole genome or part of it. So genome takes into account all the DNA in a person. A person's DNA is 3.2 billion letters. Genomics tests that we regularly use in midwifery practice and that you may be familiar with are haemoglobinopathy screening, qFPCR, microarray, newborn blood spot, CVS, amniocentesis, and so on. So for midwives, genomics represent the coming together of various disciplines and methods to inform management and care for women and their families, from taking a family history to referral for a specialist advice to initiating a screening or genetic testing ourselves. So genomics is part, and it should be part of our clinical toolkit when that help us to deliver better continuity of care and increases the chances of a successful outcome for the pregnancy. Next slide, Ralph, please. So think genomics. There are various genomic touch points, and they can help us identify where genomics can make a difference during the various stages of the pregnancy. And these are all midwifery genomics touch points. The booking appointment is, this is a very important consultation. It's crucial. It's more than a box ticking exercise. It sets the whole course of the pregnancy and the neonatal journey. It's often the first opportunity to use genomics to tailor care. From a genomic perspective, the booking appointment is a form of a screening test or a risk assessment to support us in planning the care of the pregnancy. So, for example, this is the time where we take a medical history, a family history, obstetric history. Is the time that we offer the screening test to women. So it gives us a lot of information about the parent's own or family genetic conditions, about their own genomic red flags. It helps us to identify those women that will benefit from referrals and further testing. For example, women might disclose a personal or family history of diabetes, preeclampsia, preterm birth, and sickle cell and thalassemia related disorders. The next genomic touch point is as we accompany them through their antenatal journey. They will be presented with various screening and diagnostic tests that are available to identify conditions in the baby that might cause health problems. For example, the fetal anomaly screening program. Women are offered the combined screening test, quadruple test for risk assessed the pregnancy for trisomy 21, 13, and 18. Later on the pregnancy, they will be accessing the 20-week scan for the fetal anomaly to detect any fetal anomalies in the baby, any prenatal diagnostic test, NIPT, etc. At the birth, there are several genomic considerations from a midwife's point of view. We could be the first one to notice signs and symptoms that may indicate that the baby has a genetic condition. An example of these are those babies unexpectedly born by trisomy 21. We might be the one to notice those signs and when the babies are born. Midwives could be delivering a baby diagnosed with a genetic condition during the pregnancy, or that has been identified as having a higher chance of having a condition based on a result from a screening test or because of their own family history. Also, midwives could be caring for a mother who has a genetic condition herself and puts them at high risk during the labor. For example, women who have sickle cell disease. And we could be delivering a baby following a termination of pregnancy or a stillbirth due to genomic conditions. And the last genomic touch point to mention is after the baby is born. There are a number of screening programs available to babies that aim to detect problems with the health of the baby, and many of them are genomic in nature, as the newborn blood spot, NIPE, and hearing. So think genomics. Next slide, please. So you'll be all familiar with the antenatal and newborn screening timeline. It's been used for many, many years now. Antenatal and newborn screening is an integral part of midwifery in the UK. Many of the current screening programs have a genetic component, and that is the case for the sickle cell and thalassemia screening program. Sickle cell disease is the most common serious genetic condition in England at the moment. And the main approach to the prevention of hemoglobin disorders is genetic screening and counseling. I just want to give you some figures from the National Sickle Cell and Thalassemia Screening Program. The latest data is from 2018 to 2019, the latest published data. So the NHS screened around 670,000 pregnant women for sickle cell and thalassemia. There were 341 prenatal diagnoses carried out only for sickle cell and thalassemia. 732,000 babies were tested via the newborn blood spot program. Of those, 8,200 were diagnosed as carriers and 299 were diagnosed as having a sickle cell and thalassemia related disorder. So these are very significant numbers. Next slide, please, Rolf. So what is sickle cell disease and thalassemia? Just a brief outline of what the conditions are. They are major and serious inherited blood disease. They affect the hemoglobin molecule. This is a part of the blood that carries oxygen around the body. People who have these conditions will need specialist care throughout their lives, and they'll suffer from various degrees of ill health status. People with sickle cell disease may have attacks of severe pain, have serious life-threatening infections, and are usually very anemic. Sickle cell disease occurs when there is a mutation on the beta globin gene that makes hemoglobin. Thalassemia, people with thalassemia are anemic. They need regular blood transfusion. They need medication and injections throughout their lives. There are two types of thalassemia, alpha thalassemia and beta thalassemia, depending on what chains are affected or what chains are missing. Next slide, please. So inheritance mode for sickle cell and thalassemia. Sickle cell and thalassemia are inherited autosomal recessive conditions. This means that people can only have sickle cell disease or thalassemia if they inherited unusual hemoglobin genes from both their parents, one from mom and one from dad. People who inherit just one unusual gene are known as carriers. Some people call this having a trait. Carriers are healthy and they do not have the disease or the condition. They may not even know they are carriers unless they have a blood test themselves. So I've used hemoglobin S here as an example. If both parents carry hemoglobin S, the baby is at risk of inheriting a serious hemoglobin disorder. That would be hemoglobin SS. So every time they're pregnant, they have a pregnancy together, they'll have a 1 in 4 or 25% chance of having a baby completely unaffected, hemoglobin AA. 2 in 4 chances of 50% of having babies that are carriers, like mom or dad, hemoglobin AS, and 1 in 4 or 25% chance of baby inheriting the condition, hemoglobin SS, or sickle cell disease. Next slide, Rolf. So UK antenatal screening programs. So as I've mentioned before, sickle cell disease is the most common serious genetic condition in England and worldwide. 5% of the world's population are carriers of a trait, gene for hemoglobin disorder. Antenatal, as mentioned before, antenatal genetic screening and counseling are our main tools for the prevention of hemoglobin disorders. So there is a dedicated screening program in the UK for sickle cell and thalassemia. This program allows us to identify women who are carriers and therefore likely to pass it on to the babies. And the program supports women and their families to make informed choices during pregnancy. All pregnant women in the UK are offered a test for thalassemia, but not all are offered a test for sickle cell disease. This screening depends on where the woman lives. The high prevalence areas, these are areas where hemoglobin disease are common. All women are offered testing for sickle cell disease. So these are areas where more than 2% of the booking cohort population have sickle cell disease. Low prevalence areas, these areas where hemoglobin disease are less common, they use a questionnaire to identify the family origin of the mother and the father. If the questionnaire shows either parent may be a sickle cell carrier, a blood test is offered. So this is a family origin questionnaire. The sickle cell and thalassemia screening program adheres to various standards. They guarantee that we deliver a high quality screening program. I just want to mention some of them. It's a very long list of standards that we have to adhere to, but some of the main ones are the timeliness of the antenatal screening. Women should have a screening by 10+0 week gestation. The turnaround time from the lab, the lab needs to report the result within 3 days from testing. A timely offer of prenatal diagnosis to women and couple. This means that it's by 12+0 week gestation. This means this gestation, 12+0, we would have counseled the woman, offer biological father of the baby's testing. We've tested the father, we have the result of the father available, and they've been offered PND. By 12+6, those women that want PND, this should be completed and the result reported within 5 working days. So, and you can see the timings through the pathway are very tight, very limited, and any deviations to women care will cost, any deviations in care will cause delays and hinder the quality of the care they received. Next slide, please. So currently, the only way for women to access information regarding sickle cell and thalassemia status for the baby is by invasive testing, so CVS and amniocentesis. As mentioned, prenatal diagnosis for sickle cell and thalassemia is the most frequently requested prenatal testing for a single gene disorder in the UK, with 341 tests carried out in 2018-2019. So PND should be offered to couples and women at risk of having a baby with sickle cell disease or thalassemia major after genetic counseling by a specialist healthcare professional. It can be a very difficult time for moms and their families as they are told they're having a baby at risk of having a genetic condition. In addition, diagnostic tests have a risk of miscarriage of around 1%, and this increases and this further generates stress and anxiety in the families. This means that many of them do not opt for invasive prenatal diagnosis. Genetic counseling then is essential for parents to make sense of all the information that they are provided through the pathway and to promote informed reproductive choices. Diagnostic tests for sickle cell disease and thalassemia major can tell them if the baby has the condition, if the baby is a carrier, or if the baby is completely unaffected. So CVS is done in between 11 to 14 weeks. Amniocentesis, depending on provider, is done from 15 to 16 weeks. Parental samples for sickle cell and thalassemia always need to accompany the fetal sample. Next slide, please. So what's in the future? Genomics is a fast evolving science. Recent advances in genomics have led to new diagnostic tests, such as non-invasive prenatal diagnosis. This technique involves taking a blood sample from mom to look for and assess fetal DNA. NIPD is already clinically used for certain single gene and X-linked conditions. You'll all be familiar with rhesus typing, regularly used in the antenatal clinic for rhesus negative mom, fetal sexing for families affected by serious dominant X-linked conditions, some single gene conditions like cystic fibrosis and skeletal dysplasias. NIPD is not yet clinically available for sickle cell disease, but is available on research basis through the RAPID NHS project. This is at the moment, this is researching to develop an accurate NIPD for sickle cell disease using fetal cell-free DNA from maternal plasma. As it removes the risk of miscarriage because it's only a blood test. And it is anticipated that when NIPD is available, it will be the diagnostic, so there will be no need to confirm NIPD with invasive testing. It is also anticipated that it will increase the uptake of prenatal diagnosis for sickle cell disease, as it has not perceived risk of miscarriage. Next slide, please. So just a little bit on what cell-free fetal DNA is. So when the cells die and they break down, fragments of DNA are shed into the bloodstream. This is what is known as cell-free DNA. In a pregnant woman, most of the cell-free DNA will be the mother's, but some will come from the cells in the placenta, and that contains fetal or baby's DNA. And this is called cell-free fetal DNA. That's what we are using for NIPD. NIPD works by analyzing fragments of the fetal cell-free DNA found in the mother's blood. It can be detected from 6 weeks, but we can measure it clinically from 9 to 10 weeks. And it amounts to 5 to 10% of the total circulated volume in maternal blood. The proportion increases throughout the pregnancy with gestation. It clears from maternal circulation within 30 minutes of delivery. And that's how it was identified as being fetal, and that's why we know it's fetal DNA. And it contains the whole fetal genome. Next slide, please. So genomics and midwifery, as you can see, genomics is becoming fundamental not only for sickle cell and thalassemia, but for current and screening, but for current mainstream midwifery practice. Genomics have been included within the NMC standards of proficiency for midwives, and it's been included in various government documents, NHS 10 years long-term plan, or the 2020 Genome UK. As we move forward, genomic is going to play more of a role in the diagnosis, management, and treatment pathways for parents and their babies. And we midwives, we are lead caregivers for a large proportion of women, and we must be competent in genomics if we are to meet the needs of women within the context of current work streams and advancing technologies. Midwives have an opportunity to embrace and embed genomics into practice. Genomics is fundamental to our practice. It allows us to predict and prepare for situations in pregnancy to better protect and care for the parent and child. Next slide, please. So just some resources that I've used to support today's presentation. If you want to look into a little bit more depth into any of the areas. And next slide. Just to say thank you, and I want to take the opportunity to wish you all a great International Women's Day today. So thank you very much for your time. If you have any questions in the chat or at the moment, the research is based on sickle cell disease. There are lots of just a question. Sorry, I'll read it out. Would NIPD in the future be available just for sickle cell or for thalassemia as well? At the moment, the research that's being carried out is on sickle cell disease. There are lots of complexities to NIPD for sickle cell and thalassemia, and yes, it's focusing on sickle cell disease. Hopefully, as we move on and there are more advances, it will move into other variants and other areas of the gene. But yes, sickle cell disease at the moment. Any other questions?
Morning, everyone on the line today. My name is Joyce, Sickle Cell and Thalassemia Midwife, in a way, Haemoglobinopathy Specialist Midwife, based in St. George's Hospital. And today we want to talk on my presentation, talk about sickle cell disease in pregnancy, preconception care, and antenatal care. Next slide, please. Okay, so today we are not talking in this presentation, we are not talking about thalassemia, purely on sickle cell disease, the role of the red blood cell, clinical manifestation of sickle cell disease, statistics, which we have heard some of it, preconception care, and discussion at antenatal booking, complications of sickle cell disease in pregnancy, and the approach to care, multidisciplinary team approach, and antenatal screening and routine antenatal checks, medications and treatment. Next slide, please. So the shape of the red blood cell is like a donut with protein chains within, alpha chain and beta chain. Now the role is to take oxygen or transport oxygen from the lungs to the parts of the body and return back to the lungs. They go through the circulation again, transporting oxygen around the body. Now when the oxygen is diffused, the cell should remain the same shape as throughout the process. But the problem with the sickle cell disease is that when the oxygen is diffused, the cell collapses. It takes a different shape, different form. And that is what caused the crisis, multiple pain, because it has ability to vascular occlusion, blocking the vein, because when it becomes like that, it becomes very, very sticky, not able to move through easily. Now this cell lives for 120 days, but people with the sickle cell disease, when the cell collapses, the cell then lives for 10 to 20 days. That means there's more chances that they are not having enough oxygen. Next slide, please. So the sickle cell disease is the structural abnormality it causes the structure when oxygen comes out, the cell, take a different form, a structure abnormality of the red blood cell, unable to transport the oxygen around the body as required. Then this follows these complications, beside the crisis that they experience, which is the main problem of sickle cell disease. And the crisis is the pain that they experience in their body, and it can be any part of their body, either in their lungs, in their legs or arms. They know, each individual know how the sickle cell crisis affects them or starts. When it is like that, because there is oxygen deprivation throughout the circulation, or in some ways, they end up having to have these features being affected. So they are prone to organ failure. So lung can be affected. Pulmonary hypertension is a very common thing. Chest crisis, as I mentioned. The brain, remember the capillary tube, the capillary veins to the vein, to the brain is affected if we have any occlusion. Retinopathy, remember the capillary tubing behind the eye, not able to transport red blood cells through the veins to diffuse oxygen into the eye, causes eye problem within the sickle cell disease patients. Anemia is a common thing. And spleen is the most problem, particularly when they are children. Some of the sickle cell disease have had their spleen removed. Kidney is another problem. Remember, it's multi-organ failure, so it affects every part of their body. Proteinuria is a very common thing. Papillary necrosis, renal failures, ulcers. Priapism is a condition that happens in the men when they have immature ejaculation of the penis. And that is an emergency situation that they have to be attended in the A&E. And liver problem all along. Next slide, please. So I think you heard about statistics in my colleague's presentation, which is the current one. My one says 260 to 350 babies born with sickle cell disease sickle cell condition in each year in UK. So that means it's within that statistics. Now, between April 2007 and the end of March 2017, there were 3,206 babies born with sickle cell disease in England, just England alone. Next slide, please. So what is the approach to care in terms of pregnancy? We know that sickle cell have a range of problems for the health. And they experience complications such as a cardiac stroke. They can have even stroke as from 3 months of age. So what is the approach then if we have them in pregnancy? It is something that we cannot just put them under the main clinic. Yes, we will put them in the main clinic in some places where there is specialist care not available. However, attention needs to be on this group because we will see in the following. So pre-conception care is very important for them because they have to plan, because all these babies that are being born between 260 and 350, they are growing up to be at the age of reproduction age because they are having treatment and living on. The problem is the reason why the sickle cell die early, they have a lifespan of 40 years, is because if we don't identify them and give them treatment, they are likely to die even before 3 months of age, which we have experienced that. And so it is very, very important as midwifery, we pick up this aspect of care for this pathway, for this group of patients. So preconception care it has to happen before as they're growing up. There's a pathway for children with the pediatrics, we call it. Then they call the transition. So the transition are those that are at teenagers. Now they are going to be thinking of having children when they are coming up. So the preconception care should start with them. However, not every one of them have had preconception care. So it comes to the point where we at booking, must assess the situation in a way that we need to assess their medical history, because the complication of sickle cell can affect each one individually. And if somebody has papillary necrosis or liver failure, it is not the same for the other person. So the patient in front of us, or the woman, the pregnant woman in front of us, need to be assessed individually of the condition that she's in. So it is important to listen carefully for the medical history. So preconception care prepares them for childbirth. They have to have partner, well, I would say they have to have, but not necessarily, because if they choose to have it, because when the sickle cell disease, if it is the one in sickle cell disease, and the partner is also a carrier of unusual hemoglobin, it's not more 25% chance or 1 in 4 chance the baby can be affected. It's that it changes to 50% chance, because between the two of them, they have only one normal gene. The rest are unusual genes. So it's very, very important for them to be educated about this, advice, and also if they have a partner, the partner needs to be screened before conception. Pain history, is important to take the pain history. If you can move up, because I can't see much from here, the medication side. Some of the medications they are on can affect abnormality in the fetus. Some of the medications like Remipil or hydroxyurea, which is given to those that can be on a transition, and it reduces the risk of them being on transition. So some are on hydroxyurea, but they are not. They have effects of abnormality. Much research is not done on it. So we try to make them stop the medication 3 months before the pregnancy. It's vital for them to stop the medication. Sometimes they go on the pregnancy, or they become pregnant whilst they are taking the medication. So the antenatal booking is important to review all of the medications they are having. And if any one of them is not compatible in the pregnancy, they need to stop it immediately. Immunization is also one of them. They have to have flu vaccination every year. Meningitis and other childhood immunization, they have to be on top of it, because infection is the problem. Can we go to the next slide, please? So pregnancy in sickle cell disease is a high risk. Increased mortality, morbidity, increased hospital admissions, increased fetal morbidity and mortality. Fetal growth restriction is one of the problems. Retroplacental insufficiency, increased fetal distress in labor, preterm delivery, and stillbirth. So the multiple condition and risk is on and on. Remember, it is the oxygen we all need to survive on, but this group of patients are deprived of oxygen in some ways. So next slide, please. So, oh, that didn't come, is it? Okay. Thank you. So maternal complications can be pregnancy-related or sickle-related. So when a pregnant woman, sickle cell disease pregnant, they have two things to impact on their health. There was an article I read that in the olden days, they were not allowed to have children because pregnancy was so much high risk to their lives and to the lives of the baby. However, in today's world, in this 21st century, we need to provide everybody a care. And that is why it calls for me and you as midwives to stand up and to be trained, educated, so that we can provide them adequate care. Hypertension has been mentioned, and preeclampsia is a very common thing with them. Acute painful crisis, we've mentioned, anemia has been mentioned, and infection. So when you have a sickle cell patient that has got UTI, please pay much attention, because that can be escalated and actually bring more complications on board. VT is a problem, increased cesarean section among the pregnant sickle disease. Next slide, please. Next slide. Thank you. It's very difficult to see. However, these are some of the things that has been identified, and this is also the risk that has been identified even before pregnancy. We mentioned of the preeclampsia and the rest, but I want to bring one or two things there before conception or during conception. There is 25% increased risk of miscarriage among them. So when a patient calls to say she's a sickle cell disease and having threatened miscarriage, please, it is important for us to pay more attention to them. Preterm delivery, we've mentioned that. The next one there, the IUGR, you can see there is a LFD. It means that light for date, that is the time when it was written, light for date, which is today we will say as SGA. And it's very common among them. Onto the left side, you can see PID. It's a pelvic inflammatory disease. That is also common among them. So we have to keep an eye on them. It's not like preference. They are taking preference over everybody, but it's a safeguarding their life and the life of their baby. And that is our role. Next slide, please. So what is the approach, again, apart from the preconception care? The next step is that multidisciplinary team approach to care, because they are faced with multiple conditions. And so to be under just obstetrician will not be the way forward. So hematologists are one of the team part of the team. Obstetrician, a specialist midwife. In St. George's, this is how our team runs. Specialist nurses, psychologists, also liaising with multidisciplinary professionals like the GPs, the social services, health visitors, all range of people, school nurses. Now, the question is, why do we need all of these teams? It's a big team. They are not the main, but the time will come when we have to liaise with them. Particularly, you are discharging a woman home who has a problem, maybe hematoma or something that needs to be followed up. It is important to liaise with the GP that they send another team reviewing the patient, if at home or at the GP surgery. Now, some social issues that may arise is that there may be multiple pregnancies, or the sickle patient may have a sickle disease, have a child of maybe a school age, but because of the crisis may set in at a certain point, may not be able to take the child to school. And so the child would then be missing school most of the time. As a midwife and coordinating the care for them, it's very important to liaise with the health visitor, the social workers, and offer and assess the situation to see what help is available for them in order that they can live their life in a better way. Next slide, please. So antenatal checks and scan appointments. I hope you can see this, otherwise we'll send it around. Every 4 weeks until 28 weeks, they have to be seen for antenatal checks. Now, after 28 weeks, they should be seen every 2 weeks in order that if there is anything identified, can be addressed. It's also important that they are educated to follow all appointments, because some of them may not be. There was a situation where I was looking for a patient. Let me give you this example. I called her, she's missed one appointment already. Then we book her for another. And following up, we didn't realize she was on admission. She has been admitted to another hospital without anybody knowing, and she hasn't even communicated. Until we finally got in touch with her partner, then they gave us the information that she's on admission in another hospital. So there is so much challenges around their birth. And as midwives, it's important for us to understand how this condition affects them and how we can provide them care. Regular antenatal checks, including the blood pressure, the heart rate, maternal heart rate, respiration. This is not, saturation and respiratory would not be routine antenatal for everyone, but for them, it's very, very important for us to know how their saturation is, because some of them have the saturation of 93, and that is normal for them. So if we don't know how their saturations are, and they come into labor and be not notified, it's very important. It's confusing to say that something is happening, but meanwhile, that will be the normal. But we need to know what the condition is for them. UTI is a very common thing, as I mentioned before, that is very, very important that the screening, we follow up. Any blood and any urine that has been taken for them need to be followed up and address it if it's required. Including at the antenatal booking, PCR is very important to do. So sending the blood or sending the urine samples, send PCR if you have any sickle patient in your care. Send PCR, send MSU regularly, particularly PCR at the antenatal booking. It sets the baseline for what they are of. A typical example is somebody who came in for booking and PCR was already over 300. In such cases, renal is at stake. Renal failure is ongoing, and so it is important for the team get on board to see what type of care to provide. Routine blood tests at booking, and also 20 weeks and 28 weeks, 36 weeks. I mean, including the LFT, the USNEs, the folate, vitamin B12, and iron. It needs to be checked much more often. This is not with those that are on regular transition, because for them, they're already on treatment. These are for the SCs that tend to be not on regular transition or any other genotype. Fetal well-being is very important for us to monitor them. Induction of labor normally is between 38 to 39 weeks gestation because of stillbirth, and also, because of stillbirth. Next slide, please. So another thing is that they need to get information, education on their health. It's very, very important for them to get on top of hydration. The 3 things that they need is hydration. They need to be kept warm and avoid stress, and also avoid cold. Yes, we are in a cold season. However, they need to keep themselves, they need to find a way to keeping themselves, because stress brings crisis, cold brings crisis, heat brings crisis, dehydration brings crisis. So they have to be aware of these things in order to manage themselves. And also, it's at appointment time. At every antenatal check, it's important to discuss their appointment. Appointment with hematologists, with cardiologists. Echocardiography is one of the investigations that they tend to have in pregnancy, and also renal follow-ups, and all those appointments. Sometimes, because the condition sometimes affects their memory. So you would tell them something, they can't remember what they have got, even though they have written. However, some of them can't remember. So it's over and over and over until they get it. It's not all of them that have a problem with memory, but majority tend to have problem with memory. Thank you. Shall we go to the next slide? Okay, so what if we know that they are at high risk, what then do we give them in order to manage, apart from the multidisciplinary team, advising and education? Medication is one of the main things. Unlike the thalassemia, just to make a reference, they don't have much medications in the pregnancy time. But for sickle cell, there are 4 medications that they have to be on. And this is also emphasized by the Royal College of Obstetricians. There is a green top paper which is basically used for providing care for sickle cell in pregnancy. And that is 2011, it was written. There has been a review again in 2021, but that review was done by the hematologist and obstetrician leading the review. So if you're looking for information on that, it is very important to look. The reference is all down there somewhere. When you get to the hematology website to look for it, look out for the care of pregnant women with sickle cell disease. Now, the medication is anticoagulant. It can be fragment or whichever you will give in your department. Now, folic acid is a lifetime medication that all sickle cell patients might have during, and that is to help reduce, anemia, and also, replenish the depleted folate. So they have the folic acid throughout their lives. Aspirin, in terms of the fact that they are at risk of preeclampsia, is still best as well. So they are automatically be given aspirin unless they are allergic to. But the aspirin is given at the moment is 150 milligram is given. It used to be 75, but with the guideline, it has been increased. Antibiotics, penicillin V, 250 milligram BD is their medication for life. All sickle cell patients, because of the risk of infection, they are on penicillin V. Next slide, please. Okay, so this is a picture of a lady which I picked up from the Google, and just to explain how they exchange blood transfusion, because it's not all of the sickle patients are on exchange blood transfusion. Some of them are on exchange, but some majority may not be on the blood transfusion. Now, those on blood transfusion, you can see behind there from the picture, there are two sets of bags. There's one set of 3 behind and the 2 in the front. So the set behind is the one that they are taking the clotted blood or the sickle blood, and then transfusing fresh one is the 2 in the front. They cannot be having a top-up transfusion unless in some cases that's required, and that has to be reviewed by the hematologist. Blood exchange transfusion is a process where the circling blood is being taken as well as the new fresh blood is given, and they can be there for several hours, perhaps about 3 hours in the afternoon or morning. And there's a lot of preparation they have to go through, blood tests before they go for the transfusion. And some of them can have as much as 7 units, 8 units per sitting. So it is important to coordinate their appointment, because remember, they have many reviews and many seen by different doctors, maybe in a cardiac review or renal review and everything. So it's important as midwife to coordinate their care, so they are not all the time coming and visiting the hospital, which can be frustrating for them. Next slide, please. Next slide. Thank you. Thank you. So admission in pregnancy, many at times they are admitted into the medical ward because the sickle condition is a medical condition. And to manage in the labor ward, it is something that we midwives, we are not trained to do that. However, if their admission is pregnancy related, they have to be in the labor ward and involve the team from the medical side, which is the hematology, to review them and have a plan for them. It is very important that if they feel that they are having sickle crisis, they go to the A&E. If they have any condition that is related to their pregnancy, for instance, PV bleed or any kind of that, they need to be on the maternity side. Now, admission can be early on, as I mentioned, because of dehydration, because of the condition they are having, maybe asthmatic, maybe PE, a whole range of varieties of conditions that could send them to admission. So when they are on admission, it's very important to keep an eye on them. Blood tests, which I have mentioned already, should include U's and E's and LFTs, and that's it, to check them. When you're doing a sensitive check, we may be able to identify what the cause. I remember a couple of years back, there was a lady that was admitted at 19 weeks, and she was having renal hematuria. And we didn't know where this hematuria was coming from. They checked everything. They stopped her from having the fragment. However, we discharged her home. She went to another hospital. She came back. It turned out to be that what she was having, the renal hematuria, was rather renal TB. It's a condition I had not heard before. But this is what happens because they come with sometimes challenging issues that you find it difficult to identify. But we just have to provide them individualized care. Thank you. Next slide, please. Well, thank you very much. There is a couple of information or references beneath this. Thank you for listening. Any question?
What is sickle lung?
Sickle lung is to do with the chest pain. I think I've been mentioned of that. The chest crisis. And remember, the oxygen is transport from the lungs. And so when they are not, sometimes they cannot breathe properly and they become lack of oxygen. And so on admission, it's important to assess them and offer them the oxygen therapy if it is required. I think it was on the news somehow that there was a patient who was asking for oxygen and wasn't given. If you don't know how important oxygen is to them, it's difficult to give them what they require. And also, I did mention in the presentation how or how the saturation can be low. So a patient whose saturation is about 93 all the time, you don't wait to see going down to 90. If she says that I'm having a chest pain, I think the first response is that assess her pain and give her oxygen as early as possible to recover. So it's to do with the chest crisis. Some of them have the crisis in the chest. Thank you. Have I answered you? Or any more questions?
One was about the dose of folic acid.
They routinely and recommended by the green top paper is 5 milligrams. 5 milligrams for them. And I want to take this opportunity to say those that will be anemic who may not be the sickle disease or may be just sickle carrier, because there are some AS that can recess or turn into somehow in the middle. And what they need is folic acid. Sometimes it's important to do the iron binding studies, folate and all those. And wherever they are deficient of, you give them treatment to recover. So the dosage is 5 milligrams. Okay. And then the penicillin is 250 milligram BD for the penicillin. Those that are on erythromycin because of allergic to penicillin, they are also 250 milligram BD. The aspirin, 150 milligram, and then folic acid, 5 milligram. Thank you.
Thanks, Joyce.
Thank you.
Hello, everyone. My name is Helen, and I work at Hillingdon Hospital as and a specialist haemoglobinopathy midwife. I also work on labour ward as well as a coordinator. I'm going to be talking to you about labour care. Next slide, please. This session will hopefully make you more aware and less anxious about caring for women with sickle cell disease in labour. Next slide. So care in labour is all about reducing the risks. The main risks during labour are very similar to those in the antenatal period, abruption, preeclampsia, and you've also got peripartum cardiomyopathy and the increased chance of stillbirth as well. Sickle cell crises are increased during labour and they're very unpredictable. If a crisis does occur during labour, then this should be treated as per the guidance for the antenatal crisis that's already been discussed by Joyce. Next slide. So timing of delivery. There hasn't been any randomised controlled trials to dictate the appropriate timing of delivery. However, studies from the USA, the UK, Jamaica and Africa have all highlighted the increased perinatal mortality, particularly during the later stages of pregnancy. As per the previous slide, the risks of abruption, preeclampsia, stillbirth, sickle cell crises, they're all increased. So if there are no other problems, then delivery is usually between 38 and 40 weeks of pregnancy. So this can help prevent the late pregnancy complications and the adverse perinatal events. Some hospitals will consider delivery from 37 weeks, depending on literature you read. The type of delivery. Sickle cell disease in itself isn't a contraindication to having a vaginal delivery. Some of the older studies that you might read did question whether vaginal delivery was the optimal mode of delivery. However, more recent studies have demonstrated that the vaginal delivery, they all support vaginal delivery as the mode of delivery, as well as having VBACs. The need for caesarean section should be based on obstetric indications, because don't forget, caesarean section can also increase the risk of infection and VTEs. It's important to remember that there is an increased risk of painful crises with protracted labour. So this is especially labour over 12 hours. However, this is often secondary to dehydration. So if you can keep the woman hydrated, they're less likely to have protracted labours. Caesarean section should be considered if labour is not progressing or if delivery is not imminent and there are other fetal considerations. Discussion about all this should have been undertaken in the antenatal period, and then a personalised care plan should have been made. Don't forget, the woman, she's lived with this condition all her life, and we must remember to involve her and her partner in the planning discussions and take her views and concerns into account. The place of birth, again, there's been no randomised controlled trials regarding place of birth. However, as there is an increase in sickle cell crisis and acute chest syndrome during labour, we should try and deliver these women in tertiary units that are able to manage the complications of sickle cell, as well as being able to manage high-risk pregnancies. So to that end, not all hospitals will have the experience of looking after women with sickle cell disease in labour. However, it is important that all hospitals have current and consistent up-to-date guidelines, so we can cope with any unexpected admissions. Regarding hip replacements, if a woman has had a hip replacement and wishes to have a vaginal delivery, the discussion needs to be made antenatally regarding suitable positions. She might not have, she might have poor hip rotation or abduction. So these are all things that should hopefully be planned for to make the labour easier. Next slide, please. On admission, or ideally pre-admission if possible, full blood count should be taken, group and save, and if she's got any atypical antibodies, then cross-match should be sent, because it takes longer to get blood if someone's got atypical antibodies. If she's having regular blood transfusions, then we should send an EDTA for her sickle levels, and we need to maintain IV access at all times. It's imperative that the multidisciplinary team are aware of this lady's admission. You know, this includes the obstetric consultant, the anaesthetic consultant, senior midwife in charge, and most importantly, the consultant haematologist. To work in isolation doesn't benefit women with sickle cell disease. We must all work as a team to provide the best possible care, and with her at the centre of the care. Next slide, please. So care in labour, we must remember that the room needs to stay warm with no drafts, keep windows closed. It's important for the women to be well hydrated. So, you know, if she can drink fluid, then fine. But if she can't maintain or tolerate oral hydration, then she needs to be given IV fluids. But on the other side of the coin, she shouldn't get overloaded. So we need to maintain a strict fluid balance chart, input and output. And her urine output should aim for 500 mils over 6 hours. Hourly observations should be taken: temperature, respirations, pulse, blood pressure, oxygen saturations. During labour, the demand for oxygen is increased. So, you know, use a pulse oximetry to detect if the mother is hypoxic. Oxygen saturation should be above 97% in air. If hypoxia is detected, then facial oxygen via a face mask should be given at 4 litres a minute. An arterial blood gas analysis should be taken. If the PO2 is less than 92%, then obviously she needs more oxygen. And think about giving humidified oxygen if she needs more than 4 litres. If there's any, you know, get the physio input if there's any evidence of any chest complications. Routine antibiotics, routine IV antibiotic prophylaxis in labour is not currently supported by the evidence. However, a temperature over 37.5 does require investigation, and there should be a low threshold for broad spectrum IV antibiotics. Most hospitals these days do have a septic screen policy. CTG, as we know, there is an increased risk of placental insufficiency and fetal hypoxia during labour, plus the increased rate of stillbirth, placental abruption and compromised placental reserve. So a continuous CTG monitoring is recommended once women are in established labour. Next slide, please. As said previously, an anaesthetic assessment should be taken in the 3rd trimester. This will review and discuss any pain relief that is needed during labour or for caesarean section. You know, pregnant women do have a higher rate of caesarean section. There is no getting away from that. So it's important the anaesthetic review is taken before this lady comes into labour. The analgesia of choice is definitely an epidural. General anaesthetic should be avoided where possible. It carries, you know, additional risks beyond the normal obstetric risks. Regional anaesthesia, things like epidural, spinals, can reduce the need for general anaesthetic for delivery, and it can also reduce the need for high doses of opioids if the woman has sickle-related pain. Pethidine should be avoided because of the risk of seizures when if we give this to a lady with sickle cell disease. But other opiates can be used, diamorphine, morphine pump, and Entonox can be used for short periods. After birth, the woman should remain on the delivery suite or the high dependency unit for up to 48 hours post-delivery. Again, with a low threshold for transfer to ITU if there's any chest complications or any crises arise. Next slide, please. These are the references that Joyce was talking about in her last presentation regarding the Green Top guideline and the review by the haematology. They're also at the end of Paula's slide as well. That's a brief synopsis of labour care. If there are any burning questions, I'm happy to answer them now, or otherwise we can do the questions after Paula's presented her postnatal care. Thank you.
My name's Paula, and my unit is the Northwest London University Healthcare Trust on Northwick Park, and I'm the specialist specialist sickle cell and thalassemia midwife at that unit. Okay, so it has been determined that women with sickle cell disease are high risk ladies, and they need extra care. Okay, so even after delivery, there is an increased risk of having a crisis. And there's a 21 to 25% chance or risk of having a crisis post-delivery. So clinicians need to remain vigilant. The risk is more common following a general anaesthetic. Infection sites or triggers include urine, cesarean section scar, IV sites, the perineum, breasts. So a low tolerance should be observed, and we need to treat emergent infections. Other infections or other risks include tissue hypoxia, hypovolemia, and thromboembolism. Therefore, hydration and oxygenation must be maintained, and early mobilization should really be encouraged. Women who are regularly transfused on day 3 should have a blood test to check reticulocytes, the full blood count, serum bilirubin, their HbS and C levels should also be checked. Okay, so thromboembolism deterrent stockings should be worn, certainly during the hospital stay, but also at home until she's fully mobile. The ARCOG Green Top guidelines my colleagues alluded to recommend the anti-thrombotic stockings and a low molecular weight heparin for 7 days following a vaginal delivery and for 6 weeks following a cesarean delivery. All right, so routine postnatal care, as for the non-sickle cell disease women, should be given. Ideally, she should be encouraged to breastfeed. Non-steroidal anti-inflammatory drugs can be used during the breastfeeding period. However, codeine should not be given. Dihydrocodeine, tramadol, and other opioids can be used at the lowest effective dosage and for a short while. Babies should be monitored for breathing and sleep difficulties, constipation, difficulty feeding, and weight gain. So that would be with the community midwife who ideally would go and see her. Okay, so after delivery, if the baby is at a high risk of inheriting sickle cell disease, that is, if the biological father is a carrier, then capillary bloods need to be taken from the baby to determine what type of hemoglobin he or she has. Here at Northwest London University Healthcare, we offer a day 0 testing for women or couples who may have chosen not to have a prenatal diagnosis. And in this way, the woman or the couple can know their baby's hemoglobin type before going home. Hydroxycarbamide and iron chelators should be withheld when breastfeeding. Desferrum oxide is safe, mainly due to its poor absorption. Contraception, individualized contraceptive care needs to be given to women, and the progesterone-only preparations are associated with a reduction in sickle pain. So progesterone-only preparations are recommended, so pills, injectables, and intrauterine device systems. Depo-provera is a hormonal medication of the progestin type, and it has been found to reduce painful crises by stabilizing the sickling of the red cell membrane. However, women need to be told, during that consultation, that there is a risk of unpredictable bleeding. The Depo-Provera gives a 13-week protection, and the woman would need 4 injections per year. The implant, or Neplaxon, also called etonogestrel, is a subdermal implant, and it has been associated actually with improved well-being in women with sickle cell disease, and it's licensed for 3 years. The copper intrauterine device, or the Mirena, may be considered. It lasts for up to 5 years. However, there is a potential risk of blood loss, which should be discussed with the lady before she has it fitted. Barrier methods are safe, but they're just generally less effective, or seen as being less effective. Avoid the combined hormonal contraception simply because these are associated with stroke and venous thromboembolism. I've got a few references, and that's it to do with postnatal. Any questions? Or for my colleagues?
Paula, how frequently do you follow up with postnatal patients, and also over what time scale?
All right. In Northwick Park, we don't actually admit ladies who have sickle cell disease. We deal with ladies who are carriers, so the care is a bit different. So one of my answer that, as they have women with sickle cell disease into their unit.
So the postnatal timing, routinely, as they are offered for the women, for them, according to the individualized care, if there is pressing need, they have to be followed up for 28 days instead of the 2 weeks in the postnatal period.
Right.
The situation where it's sometimes there may be other multidisciplinary team to hand over the care to them, perhaps health visitor. There has been a plan already in place in the antenatal period, which tends to be more multidisciplinary meetings in the antenatal period regarding what is going on with the patient. So it varies. Some of them will be fine. The low risk ones will be fine with the normal routine care, postnatal care. But there are some that we plan intensive care of following up. Sometimes, case conferences can come in terms of where the woman and baby is facing safeguarding issues, and a plan will be multidisciplinary plan will be put in place for follow-up. But most of the time, we tend to, when there is a case or when there is a health is compromised in a way, it's 28 days. 28 days, not 28 weeks, 28 days to follow them up and hand over. And these women, because some of them are living outside their local, the hospital, because if they are coming in for specialist care and they're in the specialist center, sometimes you have to liaise with different hospitals, because recently there has been some patients who live in Kent, and this area is very far from where they will have the specialist care. However, the care will be sometimes between the two hospitals. So before they deliver, there is also a care plan in place for them to sort of follow up. And so the postnatal is as intensive sometimes for some of them as in the antenatal period. Thank you.
There's a question here on, is there any info on a new diagnosis of HBCC baby. We have had HBCC babies delivered at Northwick, and it is a disease state because that baby doesn't have any normal hemoglobin. However, it's not a significant disease. That baby will be looked after for a while. They'd be seen in, for example, with us, babies are seen in Central Middlesex Hospital, in the day centre there. But it's not, you know, they're not going to have crises or huge problems as the SC or SS baby. So, you know, they wouldn't need follow up for all of, you know, for all of their life or anything. Simply because they wouldn't have, you know, they're not going to have that problem.
They're not going to have that problem.
Well done, Paula. That's good said. Yeah. Because it's unusual hemoglobin, so they haven't got normal hemoglobin, but it's not severe. The S is the problem. So the S combining with any other genotype is the disease. Any other, it can be a disease. The S combining with them all. So with the, if somebody can have DD, CC, as you asked, so that is not seriously true. So they will present themselves like a carrier most of the time. Thank you.
There's also another question about are these women usually delivered in tertiary centres? And yes, on the whole, they are. It depends on antenatally how many crises they've had. Have they had any ITU admissions? And other factors, generally how they are when they're not pregnant, to depend on where they will be delivered.
Sorry, I had to from my. I'm not sure what's the laptop. Okay, so I'll start. My name's Rosalinda Olayode. I've got 3 children, a 5-year-old, a 2-year-old, and a 3-month-old.
Wow.
So, yeah, so 3 kids under 5, about 5. So yeah. I've got sickle cell, I've got SC disease. My mom's got full SS disease. Up to pregnancy, sickle cell didn't disturb me too much. Maybe I just had the acute chest infections regularly. So mainly issues with my lungs and pneumonia and various episodes regarding that. But during my first pregnancy, I was closely monitored. I was offered to have regular blood transfusions, but because my sickle cell had been pretty good up to that point, I refused because I had never needed blood before. But after the birth of my first child, I developed one of my lungs. I had severe pneumonia. One of my lungs almost collapsed. So I was almost rushed to ICU, and I had to have my first blood transfusion at that point. So going forward, I had a different care plan. So with my second child, I still didn't have the regular blood transfusions, but I did agree to exchange blood transfusion prior to delivery. So my first birth was a cesarean. My second birth was a natural delivery. But one of the reoccurring patterns that we noticed is once I hit almost 10 centimeters dilated, I would start developing an infection. I would be shivering profusely. So the first one I was rushed to, I had to have an emergency cesarean. So for the second one, I had a natural birth, but I had the same infection again around delivery, and I lost quite a lot of blood. So it was good I had the exchange transfusion because my blood levels dropped just below 5, I think, my HB. And for my third child, I just said, I think everyone agreed that it was just better to have a scheduled cesarean section. And also with my third child, I had placenta previa. So I had a low-lying placenta, and I had various bleeding episodes, which I had to be admitted into hospital. Actually, with my third child, I think I had to go into 3 different hospitals at one point because I had a bleeding episode when I was quite far from home. I think I was in North London, so I went to Northwick Park, but they didn't have specialist sickle cell care for pregnancy, I believe. So I was transferred to Queen Charlotte and then transferred back to my home hospital of St. George's. And so I found that the exchange blood transfusions before delivery actually helped me with my whole pregnancy journey. I don't know if there's any questions you have for me as somebody living with sickle cell and being pregnant. And yeah.
Rosalinda, what was your experience of the screening process, and maybe your children? I mean, I don't know if the father of the baby is a carrier or not, but if he is, your perception of risk towards your children, your own experience of the disease, how you feel about your children being possible carriers of disease themselves.
Okay, so I've been closely monitored for sickle cell since I was young with a consultant. So I kind of knew that I had to, my only way out was really AA. And also having seen my mum go through sickle cell and crisis and having experienced it myself, it's not something I really wanted for my kids. So before I got married, my husband was screened by my consultants. They offered him a blood test to screen him, so he was AA. And one of the things that did happen at every pregnancy, I heard it was a requirement, was he was screened at every for all 3 children to make sure that everything was fine. So my kids are all carriers, but none of them have sickle cell.
Thank you.
Any other?
And Rosalinda, did you feel that you were involved in the care decisions during your pregnancy?
Yes, I did. I mean, one of the things I really noticed is I was very closely monitored. I think I had appointments every 4 weeks where I would have routine checks. Sometimes I did complain because it did feel like a bit much, but I did realize that I was getting the best care for my condition. Especially after the first pregnancy, I think I didn't take it for granted anymore, that specialist care for sickle cell. So I think the first one I maybe, but by the second and third, I was grateful that I had that. And I was involved in the decisions. I saw my obstetrician looking after high risk, and I could say, this is what I want, this is what I don't want as well. So yes, I feel like I was carried along and they did listen to me.
Yeah. Good. Is there anything that you change about the care that you had?
No, I think fine. I don't know if I would still have the regular blood transfusions for me personally, just because prior to childbirth is the one I did the blood for. But I think change transfusion before birth is definitely needed. But I don't think there's anything I'll change about my care plan. I think it was really good. And it also helped me, for example, when I ended up in a different hospital, that I could tell them what was going on because I was carried along in all the decisions. I knew exactly what was supposed to happen to me and how my son was treated. So it's good when I got to another hospital that they didn't know me. I could tell them
Rosalind, did you feel, because you were admitted at a non-tertiary center, as unit that wasn't specialized in sickle cell and thalassemia at some point during the pregnancy. Did you feel the care was different? Did you feel the hospital was able to cater for your needs at the time, or
I actually feel they went over and above, which was really good. So I think I was a bit worried at first when they said, oh, we don't have any sickle cell specialists. But it's actually funny because I was born at that hospital that I was admitted. So I think previously they had sickle cell specialists, but maybe they don't have that anymore. But so I was a bit nervous when they said they didn't have it. But I think one of the good things that I also found is when you have, so I've had the same sickle cell midwife, Joyce, for my 3 pregnancies. So, and I've been able to contact her when I felt sick, when I've randomly been bleeding and like what's going on, I don't know. So I think that care was really helpful for me, because if I felt like I was having a crisis, or if I felt unsure of what was happening with me, I had someone to contact. I'm not sure that everybody has that. So I could reach my midwife, I could reach her and say, I'm having this, is this normal? Or should I be concerned? Is this more my sickle cell tripping up, going off? And she was also able to educate me about pregnancy and sickle cell and what complications I should look out for. So I was a bit worried when I got to Northwick Park, that hospital, but I think they went over and beyond in my care to make sure that I was settled.
Great, excellent. Thank you.
Joyce, that's great to hear. I'm the specialist midwife at Northwick Park. We, like you say, we used to care for ladies with sickle cell disease. I'm not sure of the history, and I know we don't know, but in what way do you feel that we went over and above?
I think they were just, they checked everything. So the first thing they knew, so when my chest started hurting, and because I'm used to having chest infections that relate to my sickle cell, they did the ECG straight away. They got a specialist to check. I mean, when I actually got to Northwick Park, if I just give you a bit of background, I was brought in by ambulance. I lost quite a lot of blood while eating dinner at a restaurant. So I was rushed in. My HB had dropped quite significantly, and they had to give me blood. And it was sort of, there was like all these doctors in the room all of a sudden, are we delivering this baby now or not? I felt everybody was really hands-on, which I was a bit scared because I'd lost a bit of blood and I think I was becoming unconscious a bit. I was quite scared. So, and I just know there was a lot of people in the room all of a sudden, and decisions were being made around me. But I do feel like they went over and above. They kept explaining everything that was happening to me and to my mum that was in the room. And even when I had to call my husband that was out of the country, they were really attentive. They kept explaining everything to me. They liaised with, I know this, probably every midwife will say, why did I do this? But I didn't have my notes with me as well. So I had to get notes as well, so they could get some background on me. So they were really attentive. They listened to everything. They gave me blood when they could transfer me safely to, I think I went to Queen Charlotte's after that. So still not my home hospital. I went to Queen Charlotte's. There was no space at St. George's. I think they just went over and beyond. They made sure I was comfortable in the care they gave me.
Great. Lovely to hear. Congratulations anyway on your safe delivery.
Thank you. And I ended up staying from that episode. I think I ended up staying in hospital for 3 weeks till I did give birth, because nobody was letting me out anymore.
I think this tells how complicated sometimes things can be for this woman. It is a typical example. There was a lot of communication. One thing I will encourage that if you have anyone on your care and need to be communicate with a team outside the other hospital. A lot of information, care plans were emailed, sometimes Sunday. And I thank God that not everybody will have the access, but the access was there to sort of send them information and follow up and liaise with the doctors at the same time. So it's quite intense looking after them. I always say that there are not many, but looking after them is a lot of commitment, a lot of devotion to them, and making sure that themselves and their babies are safeguarded, in their health and safety. So that's what I would say. Sometimes you are sleeping at 4 o'clock and somebody will call. Somebody will say that odd hour and you're going to work. However, if you want to save them, sometimes it's good to. You are there for them. Not everybody will say that. Even the NHS and guidelines will say that when you are finished work, you are finished. But in providing care for the sickle, it's 24 hours on the clock. Thank you.
You never know when we're going to have.
Sorry?
I said you don't know when we're going to have. Or lose some blood. So yeah, I mean, losing blood for me was very scary through pregnancy. I think I lost blood more than once. I think I had 3 or 4 different bleeding episodes. That was quite, and it's almost, when is it serious enough to call? You never know when it's serious enough. Yeah, so it was an interesting.
Thank you very much. Thank you so much.
All right, thank you. Any other questions? Okay, thank you.
Okay. Thank you so much, Rosalinda, for your excellent talk just then, and also in answering the questions. And thank you so much to all the staff who presented today, to Helen, to Paula, to Joyce and Carmen, and for Shauna for kicking us off. As most of the people on the call will know, we have a rerun of this session on the 31st of March, which is a Thursday, between 2 o'clock and 3:30. And so if you would like to recommend any other midwives come along to that, please do, and they can email me directly and I'll get the link out to them. In terms of a recording of this session, we'll probably send one of those out the day after the session in March. So that'll probably come out in early April, and that'll be available through the network's YouTube site. So again, thanks everyone for attending and contributing to the session. It's really appreciated.
Thank you, Ralph.